All right, good afternoon, everybody. Welcome to the December 2019 Community Paramedicine Insights Forum. Our presenters today are Desiree Partain and Matt Zavadsky from MedStar Mobile Healthcare. Matt, we'll let you take it away.
All right, thanks, Gary, and I'm sure you'll monitor if people say they can't hear us very well. I'm going to let Desiree introduce herself first, since it's always ladies first.
Good afternoon. My name is Desiree Partain. I am the Mobile Integrated Healthcare Manager here at MedStar in Fort Worth.
Thanks, Desiree, and I'm Matt Zavadsky. I'm the Chief Strategic Integration Officer. I've been dabbling a little bit in this mobile integrated healthcare, community paramedicine space for about the last, we were just calculating 11 years.
Yeah.
And we're still employed.
Yeah, you're showing your age, too.
Just because you're half my age doesn't really mean anything.
Yeah.
All right, so here's what we're going to try and go over. Gary, you said we had about 120 minutes to do this, so we set some discussion goals. First is talk briefly about the continued economic challenges for this mobile integrated healthcare community paramedicine space. Talk about subscription programs briefly so that people who might not be aware of them at least get a little bit of an introduction to them and some of the regulatory requirements for that. Learn about the healthcare gap that Desiree and her team have found that we might be able to use this type of a program for, and she's got some good metrics and program overviews. Understand the goals and the metrics of the program. She's going to share with you some of the scars, right, that we learned in the implementation.
Yep.
And we're going to learn a little bit throughout the presentation about kids' perceptions of love and marriage. So let's do that first one just to kind of have some fun kicking this off. So this was a survey or questionnaire that was given to kids between the ages of 7 and 10-ish about questions related to love and marriage. So here was the first question that they asked this group of kids, and how do you decide who to marry? And you got to love Alan's response here. You got to find somebody who likes the same stuff. Like if you like sports, she should like it that you like sports and keep the chips and dip coming.
Yeah, that's very great advice.
Is that how it goes in the Partain household?
The other way around.
No person really decides before they grow up who they're going to marry. God decides it all way before, and you get to find out later who you're stuck with.
Stuck, yeah, that's an interesting
Very
term.
good. Arranged marriages, right? So for many of you on the webinar, the economic viability and sustainability of mobile integrated healthcare and community paramedicine continues to be a little bit of a challenge. In 2018, NAEMT published a survey. It was the second survey on this service line. And the respondents said that this continues to be a challenge for them. Now, 44% said that they were generating some revenue, which was up a little bit from 2014, but a lot of them are still grant funded. And as we all know, grants are not a sustainable form of revenue. In fact, it's sort of interesting that we still get emails from folks around the country that says, hey, how do I apply for more grants to keep sustaining our program? Not always necessarily a terrific strategy. When those same respondents were asked, what is the future of the potential financial sustainability, they were sort of a mixed bag. And you can see that on the chart here, that only about a third felt that their program is financially sustainable. So we have a lot of work to do to keep turning over different rocks to see how we get these types of programs funded. Now, the ET3 initiative may help move that along a little bit, but we'll see how that all goes. Here's where some of the funding is coming from. So you can see that in the same, let me explain this survey. So about 3 months ago, NAEMT sent out sort of a flash poll. And for those of you that are in the iChiefs or NEMSMA are aware of these flash polls, but we sent a quick survey with about 9 questions to agency leaders from across the country, all different types of services, and said, hey, are you getting paid for non-traditional services? And here's some of the responses that you can see. So in this particular question, asking is your agency paid for your non-traditional services? So that could be alternate destinations, alternate response, community paramedicine, all stuff that goes along with that MIH strategy. And you'll see some of the results here that a fair number of the paid services were getting paid for the enrollment-based home health care delivered by specially trained paramedics, so what we typically refer to as community paramedicine. But only 37% of the people that responded to the survey answered this question. So we have to assume that the rest of the people are not getting paid, and they didn't want to say that they weren't getting paid. Or they just assumed that, yes, I'm getting paid, and here's how I'm getting paid. So some of them are getting paid from a governmental agency, so that could be their city budget, county budget. Funding, we know it's not the feds for the most part. Could be Medicaid funding. Notice that the majority of the folks are getting grants. So again, we just know that that's not a long-term strategy. And also, a lot we're getting paid by other healthcare providers, so hospitals, home health, hospice agencies. A lot of the programs that we're doing here at MedStar are similarly funded. So relying on other providers to pay for our service also probably is not a great long-term strategy. So this is something that we here at MedStar, as well as some other organizations, do continue to face. So for those of you that aren't aware, ambulance subscription programs, or sometimes referred to as membership programs, have been around for a long time. They're pretty prevalent in some areas of the country, Pennsylvania, Minnesota, I think, Florida. And this is where the ambulance provider offers a subscription to households, individuals, however it's structured. And for being a member, you generally either have your deductible, coinsurance, uncovered portion, uninsurance covered portion of your ambulance bill written off. And that's one of the benefits of being a member, and a lot of folks subscribe because they won't have any out-of-pocket charges for the medically necessary ambulance trip. In the event that there's no insurance, the fee for the enrollment into the membership program is generally a little bit higher, and essentially they get a discount off of the fee, not a complete write-off, because if there's no insurance payment, you've got to make some type of payment from somewhere. So, for example, in the MedStar system, our subscription fee is $69. If you have insurance, if you don't have insurance, it's $110, and that's per household per year. And if you don't have insurance, when we transport you to the hospital and we send you that $1,495 bill on average, we discount that 40%, so that buys you a little bit of that. Same thing about subscription programs. Some states consider it insurance. Connecticut, for example, considers an ambulance subscription program insurance. So therefore, ambulance providers cannot do this. And some states, again, consider this insurance. So you got to make sure that if you're thinking about starting a subscription program, that it's legal in your state. A lot of states do allow it. You also have to make sure that the program is financially sound. That means that you cannot take a loss on the subscription program in return for selling subscriptions. You also cannot make a ton of money. So the state agencies and even Medicare will look to make sure that your subscription plan is fiscally sound. So we do this analysis annually at MedStar. We look at the revenue that we generate from the subscription programs. We look at the amount of money that we wrote off for subscribers to make sure that those numbers close to balance. Because if it's too high on one end or the other, then you have to make some allowances, some changes to the pricing structure, the methodology, to make sure that it's not either a kickback, meaning that you're just discounting services, or that you're making an arbitrage profit, because that could get the insurance companies a little bit persnickety. These are some examples of marketing things that are done by ambulance services across the country. You do see air ambulance services quite a bit offering subscription programs. So CareFlight is a big air and ground provider here in the north central Texas area, but you'll see examples from around the country that are these types of subscription programs. So they are pretty prevalent. They can help improve the financial impact on patients, which is really the primary goal, but also it's a great way to help pay for some marketing for your organization, whether you're governmental or whatever, it doesn't matter. We talked briefly about the MedStar membership program, but that's essentially how it works. And we've had this since MedStar was created by interlocal agreement back in 1986. It's actually written into the interlocal agreement that MedStar must offer this to make sure that the financial impact on the patients is minimized. Now with that dry stuff, let's talk about something that's a little bit more fun, another series of questions on kids' perspectives of love and marriage. When is it okay to kiss someone? Here was really the first honest answer from Pam: when they're rich. Right, that's a good reason to kiss someone. Yeah. The law says you have to be 18, so I wouldn't want to mess with that. Yeah. The rule goes like this: if you kiss someone, then you should marry them, have kids with them. It's the right thing to do. So, all right, now we're going to transition to Desi, who's going to walk you through what we've done here in Fort Worth with some fun results.
So speaking of relationships, right, because that's one of the things we're also covering, marriage and relationships here. In our service area, we have formed really close relationships with organizations in our community. And so we had a large independent living facility that actually came to us and approached us and said, hey, we have a gap in providing some services to our residents. So the gap being, at one point, their residents were receiving this on-call nurse service in which if they had an issue or they wanted to be seen by their nurse, they would request the nurse. They would have a nurse come from their skilled nursing facility unit and go see the resident in their apartment. Well, after review, the independent living facility realized that this was not something that they could do. So they couldn't take the nurse out of the skilled nursing unit, and so they were no longer able to provide that service to the residents. So in the interim, what they were doing was they have a security staff who are trained emergency medical technicians, and in their interim, if a resident had a medical request, they were using the security for those requests. And as the slide represents here, the residents were looking for a little bit more than just the kids in the basement. So when we talk about the kids in the basement, their security staff actually, their offices are down in the basement. But, you know, going from a service being provided by a nurse and now a service being provided by what their perception was a security was just, you know, from a resident perspective, they wanted a little bit more. Not saying we're, you know, it's downplaying a nurse in comparison to an EMT, but when you're given a certain service, there's certain expectations. So getting feedback from the residents at the facility led their leadership to kind of explore, well, how can we help to provide at least this service to these residents, bridge that gap. So they actually reached out to us because they had heard about our mobile integrated healthcare program, some of the things we had been doing in the community as it relates to our nurse triage, 911, and mobile integrated health services. And we initially met with them a year and a half ago.
5 years ago.
It wasn't 5 years ago. It feels like 5 years ago, but it was not. And they approached us and said, hey, we have this gap, and how can you help to leverage having this on-call service to our residents? And there's where the opportunity presented itself. So we, as an organization, after hearing what their gaps were, we met internally to help determine how we can bridge some of those gaps. So from that, we created certain and very specific goals. Those goals, as they related to the residents, was providing 24-hour service, or what we call on-demand services for the residents. And really, the safety in this was having a provider that the residents trusted. And, when we go back and look at our utilization, we respond to this independent living facility on a pretty frequent basis. So they're very familiar with the paramedics and EMTs on the ambulance. So, there's a certain degree of trust in our providers because they see us on a pretty consistent basis. So, from that came this kind of MedStar on-demand concierge medicine approach. So providing that 24-hour on-demand and then patient navigation on 911 calls. And really the goal is that care coordination to ultimately prevent unnecessary trips to the emergency room for these residents. Because remember, these residents before, when they were having whatever ailment or condition, they were calling a nurse. And that nurse was really, in a sense, providing that timely health care to prevent them from calling the emergency room or calling the ambulance and being sent to the emergency room. On the facility side, the ownership came of providing compliant a compliant and cost-effective solution for the residents. Also, increasing resident satisfaction. So when they lost this service, the residents there were pretty vocal about not really being happy with losing a service that was being provided to them.
That many of them moved into
knowing
understanding that they were going to have that.
Right, that service line. So increasing resident satisfaction, and really this is, in a sense, kind of a marketing tool that the facility is using when bringing on new residents to their facility.
Now, Desi, you've made the comment that you would like to live in this facility. This is not necessarily your typical independent living facility. What is the facility like?
So this facility is pretty spectacular. I actually went there last weekend and went to a resident's apartment. They were actually on the 10th floor, so an amazing view. They actually have 3 towers, and they have close to 350 apartments. And so this isn't like, an old hotel or whatever. They have three towers. 2 of them are actually most recent that were built a few years ago. On one of their top floors on their tower, they have a full restaurant. I mean, it's very, very nice. So the amenities in this facility are very nice, and it's actually located in the central part of Fort Worth. So it's close to, our downtown area and things like that. So yes, I would definitely like to live there myself. So knowing what the goals were for the residents, what the goals were for the administration, the next step was putting a plan in place. And the plan being enhancing the Star Saver membership that we already had. So we went back and said, okay, we provide a Star Saver membership, and here's how we deliver that service. Maybe there's an opportunity for us to provide a Star Saver Plus membership. And what would that plus mean? Well, plus meaning maybe we could offer this concierge on demand. So when a resident has a request, and they normally would call a nurse, well, why don't they contact our communication center? We provide a 10-digit non-emergency number. When the resident has a request, what we can do is send our community health paramedic to that resident's home to do an assessment and further care coordination from there. So there's the non-emergency component, and then also providing a co-response on 911 calls. So we realized that we average probably between 20 to 30 911 calls at this particular facility, so we knew there was definitely an opportunity to do care coordination on the 911 side. So when a resident calls 911, not only are we going to send an ambulance, but why don't we include one of our critical care paramedics to co-respond with that ambulance to provide that additional layer of enhancement and ultimately provide that care coordination piece. So knowing the gaps, knowing what our plan of action would be as far as the service line, what we also wanted to address was our further plan as issues as it relates to an economic model. When we look at the economics into this program, we really wanted to see what the utilization would be to make sure that we priced it accordingly. So what we did was we went back and looked at the last 12 months of 911 calls, and that's where we got our average of 20 911 calls a month. So knowing that, was this feasible for us to do? Did we need to increase our staff in order to meet that demand? And also getting some information from the independent living facility to say, okay, well, how often were they calling the nurse, right? So are we talking like 1 to 2 calls a day, or are we talking 10 to 20 calls a day? Because that also had an effect on the overall utilization of the program and how the pricing structure was going to be. And because we're deploying our community health paramedics or our critical care team on the emergency and non-emergency side, you have to make sure that you have processes and protocols in place to address any healthcare issues and really that care management umbrella. So really, we worked very closely with our medical direction team to make sure that we had a process in place to address those issues. Member enrollment is definitely something that you have to take into account. Remember, talked about at this particular facility, there's over 350 apartments, and for the most part, all those apartments are occupied. It's a very popular place to live.
Despite its price.
Despite its price. So we had to think about, was this something that we were going to open up for all of the residents there, and who was going to be paying for this, and, were all the residents, despite who was paying for it, were they going to be enrolling? And if so, how were we going to enroll all these residents? Were we going to do it on site, go up to each resident's apartment? And then what was the information we were going to obtain? Because what we found was really important in kicking off this program was making sure that we made face-to-face, in-person contact with each resident before we went live. And a component of that was getting baseline medical information, demographics, confirming their if they had out-of-hospital DNR, things like that. I think that was an important component to making this program successful, was really meeting with those residents face-to-face, having our providers that they were actually had the potential to see if they called the 10-digit line, having that face-to-face interaction. Also, coordination with their PCP and doing notifications, so letting their primary care providers know that, hey, your patient is enrolled in this particular program, so there may be in the future an opportunity to do care coordination. So you may receive a phone call from a MedStar paramedic at 2 in the afternoon that has a question about your patient. So, not to surprise that PCP, but for them to be aware of the program as well in order to navigate these residents to the most appropriate healthcare destination. Confirming their contact information and, fax numbers, because what we try to do is fax our EMRs to their attending physician so that everybody's on the same page. Flagging these patients in our computer-aided dispatching, making sure that we have the right response for these residents, making sure that they were put into all of our different systems here, and also having an agreement in place prior to launch of the program, because we were sharing health information. So we did sign a BAA with the facility because they were owners and really they weren't a covered entity. So those are the things that you need to think about when wanting to do a membership program when it comes to the economics, clinical, program processes, the beginning, enrollment, care coordination, all these little processes that people don't necessarily think about.
So Desi, the enrollment of these residents into our MIH program is a little bit different than the traditional, hey, we're going to see somebody twice a week for 30 days or 90 days, whatever the case might be. How was the medical director, our medical director, Viability, notification to the PCP, sending the protocols to the PCP, so at least there was a notification to them? Because these patients, we might do just a one and done once a year on a 911 call. How did we work through that process?
So our medical director, he's been up to speed on all of our programs, so I don't think any real issues from our medical direction side. The biggest thing was relaying that information to the patient's PCP. So we have basically a template that we're able to send to the patient's PCP to let them know, hey, here's our protocols. Here's what we have in place in the event that your patient were to call 911. Here is our processes. And if you have any questions, please contact us. If you have any questions about the protocols or there's some, discrepancies that you see, because ultimately we want to do what's best and what's in line with that patient, with that resident and that patient's plan of care.
Right, and primarily for Dr. Viability, it was if we can't reach the PCP, we're going to use this protocol,
Right.
and we may not take the patient to the hospital. And he just wanted to make sure that the docs were at least notified, hey, here's what we may do with your patient, so there was that communication.
Right. So before we go live with the program, what we want to make sure is that we're pricing this program appropriately. So we went back and looked at any related costs as it had to do with payroll for our team, looking at other various expenses, so equipment, administration. We looked at field unit hour costs, our vehicles, our equipment, and other various supplies in relation to our contacts and hours. And when we tallied all of those numbers up, we were basically able to get an overall cost per patient contact for each resident there at the facility. So that's the $170 that you see there. So what we did was we took that number, the cost per contact, and averaged that cost per contact with the number of contacts that we thought we would make per year. So that's where you see the 1.5, plus the program cost, which was $255. We added on the Star Saver base that we charge for our normal Star Saver membership, and then got an overall cost of $324. So we ended up pricing the program per household at $350.
And one of the things there, we averaged that 1.5 contacts, and it will be covered later, so I won't talk about
Sure.
it.
All right, so going through some of these processes.
Let's go back one.
Sure.
So what did the facility think about this option? So we initially met with the residents. We met with the resident president, right? So they had like an HOA for the ILF.
Right.
And the original plan was who was going to pay the subscription fee?
Was the residents were
Right.
going to be paying for this.
So the facility wanted us to propose this to the resident
Right.
council as, hey, if you want this, it's going to be $350 a person, $350 a household,
Right.
and there you go.
Right.
What happened later?
Well, then, so we were ready to, roll this out, but then we got a phone call from the facility, and the facility actually said that they were going to pay for the cost. So this is actually covered for the residents by the specific facility.
So it's free to the resident.
Correct.
So whatever resident signs up, the facility writes the check, and they cover the cost per each resident per year.
Correct.
And why do you think they would do that?
I think it relates to customer service.
And keeping them quiet.
Resident satisfaction, correct. All right, so now our plan is rolling this out is that initial in-person contact. So setting up that enrollment visit. So each resident, each household receives that initial enrollment visit. And during that visit, we would go over, like I said, the physical, medical assessment, primary and secondary, of the primary and secondary Star Saver member, their basic demographics, any perceived medical or healthcare gaps, making sure we document those. And each resident has a patient profile within our electronic medical records. So at any time, if a resident calls us, our team has the ability to go into the system and kind of look back at any previous encounters or their overall patient profile, so they know ahead of time, a little bit about the resident. Any medications. So what we ultimately decided was we weren't going to write down a list of medications. So what's interesting about this facility is each resident has a door packet. So if you were to go into the resident's home, they have a packet behind their door that has a list of their updated medications and any health information, out of hospital DNR, living will, and things like that. That it's really up to the resident to update. And we realized that it probably would not be in our best interest to have a list of medications during this enrollment when it can continuously change, either by day, by week, by month. But so we made sure that we went over the patients, that they were updating their medications and their history, and just reminding them that it was important to update their packet and any pertinent documentation. So during that enrollment visit, we'd have the resident bring down their packet. We went over each piece of paper within that packet and if they had any questions about that. Once we met with them, we made sure to register them in our systems. And part of that is notification to the primary and secondary members, PCP, of their enrollment into the program, and sharing our protocols of the program. And they were also flagged in our computer-aided dispatching in the event that they call 911 or they even call the 10-digit line. They're flagged in our system, so we recognize them at the time of that call to make sure we send the most appropriate resource to them. If this is a 911 call, like I said, we send the ambulance, but we also send a member of our team to co-respond with that ambulance. So they have the 911 service line. They are also, during that year membership, they receive up to 2 additional non-emergency in-home visits per year. If they have some sort of issue, and we'll go over a case study specifically, but if they have some sort of issue and they request for that community health paramedic to come out, that is an example of an in-home request. Now, they're covered for 2 in a 12-month period, and we're also tracking this every month. So if they exceed more than 2, that resident will get a bill at $200 for every time we have to go out there to do that in-person visit. All right, so we have gone over, some of the processes, the whole, meeting with the resident. We actually executed everything before we met with the residents, but, the facility agreed to fund the program, so that was, pretty significant for us and for the residents. We executed the BAA and, developed town halls and meetings. So prior to launching this program, we got with the facility and we ended up doing several town halls in which they would coordinate having all the residents come down at different times, and we just talked about the program. We introduced the program, what MedStar does in relation to this specific program, and really just left it up to the residents to answer questions, to voice any concerns that they may have had, to tie up any loose ends. Like I said, this was really an opportunity to meet with those residents face-to-face before we went live in order to refine any processes. Each resident had to do an individual application for their household, and this process took about, it's funny, so Matt initially put 2 weeks on this slide before, and I was like, oh, no, this process took 6 weeks. So we basically camped out at the facility. It was very nice. They reserved a couple rooms for us, and we worked out with the facility that the residents signed up for time slots. So we got, for example, we arrived at the facility at 7:30 in the morning. We started our first visit at 8 a.m. We structured the visits to be 30 minutes, so we felt 30 minutes was enough time to be meaningful, but enough time to keep us on track. And so we met with each resident for 30-minute blocks up to about, 6 p.m. And the residents that weren't able to meet us in person for whatever reason, mobility issues, we would go and find them in their apartments. So that total took about 6 weeks. And there was still a handful of residents that, despite our best efforts from ourselves or phone calls or from the facility, still weren't able to reach. But we still ended up flagging them in our system in the event that they call 911 or they contact us on our 10-digit line.
It was interesting, during the town hall meetings, obviously the majority of the people were very excited, happy they were doing it. They were a little suspicious of the parent organization funding it because they said they're just going to pass it along on their HOA dues and it's going to be collected somehow, but the facility ownership assured them that would not be the case. But honestly, a lot of the feedback that we got, not a lot, but some of the feedback that we got was that they thought it was too good to be true.
Yeah.
They kept saying, what's the catch?
Yeah.
What's the catch?
Mm-hmm.
But no, there's no catch. This is really just going to be cool for you guys.
Yeah.
So it was fun.
And this is just an example of the flyers that we were providing to the residents when we went to do the enrollment visit. We would give them this flyer that they could either put in their door packet or up on their refrigerator that just acted as a reminder about the program, the goals, the services that were being provided to them, and then phone numbers for that 10-digit line. All right, so let's get back to the fun parts. We're going to talk about relationships and marriage, obviously from kiddos' perspective. So, question is, what is the right age to get married, right? Because we're talking about relationships. So Camille said 23 is the best age because you know the person forever by then. 23 is, yeah, you know that person forever. How can a stranger tell if two people are married, though? This should be interesting. So Derek said you might have to guess based on whether they seem to be yelling at the same kid. I know nothing about this.
Says that you have 2 kids under 2 or something.
I have 2 kids under 2 and I have 2 teenagers, so I know nothing about this. All right, so let's go over outcomes. We went live with this program only 2.5 months ago. It feels like a little bit longer than that.
You have a lot more gray hair than you do.
Yeah, at least I have kept the hair, right? I wasn't saying anything about you. No. Just give me a year, right? I might not have these locks. Okay, so we went live October 1st, and we ended up enrolling 335 total residents. When you break that down, there was 240 households. So remember, some households have more than one person. So total, we ended up with 335. Since then, we have had 2 episodic requests. So when I say episodic, this is when a resident has initiated in calling our 10-digit non-emergency line. And we've also had 34 total 911 calls for the month of October and November. So we're pretty in line with what we had thought that utilization was going to be per month. Out of those 34 911 calls, a critical care paramedic was on scene 25 out of those times. And out of those, out of the 25, the resident was transported to the emergency room 21. So there was actually 4 times in which that a resident was not transported, and we provided alternative care in that resident's home. So when you look at overall, there were 6 times in which we did alternative care coordination. So just think about that. While that you may think that number is low in the 2 months, these are 6 residents that ultimately were going to be going to the emergency room.
Right. Because this is a kind of at-risk population, and almost always when we go there, it's a first-party caller,
right,
and they always go to the emergency
room.
Right.
All right, so let's talk about a specific case study. So we had, in our first month, it was like a week in, I think, we had a resident who called our 10-digit number and basically said, hey, look, a few days ago I had a flu shot, and now I'm just not feeling well. I feel like I have the flu. So we ended up sending one of our paramedics out to that resident's home, and looking at that time frame, but from the time the resident called until that paramedic made scene was about 15 to 20 minutes. We give a 60-minute window when they contact our 10-digit line, so we were able to deploy that critical care paramedic out in a timely manner. That critical care paramedic went out, and I think they actually met in one of the common areas down in the lobby. So we met in a private area that did an assessment based off of initial assessment. Really didn't find anything acute. We did do a Chem 8 just to make sure we were ruling out everything in relation to what that patient's complaint was. And, maybe some slight abnormalities, I think, in the patient's sodium or potassium, but, nothing crazy. But so we ended up contacting that resident's PCP and reviewed our findings with the resident's PCP, and navigated that resident to the PCP, and they were actually able to get into their PCP later that afternoon. Resident was able to drive himself by personal vehicle and made the appointment that same day. We sent our report over to the PCP, and he went to the PCP. He did additional blood work and was told by the physician to follow up, and he was waiting on his lab results. What we ended up doing was we had our nurse case manager contact the resident the next day just to follow up and see if there was anything else that we could do. Resident said, nope, got to my doctor, did some more blood work, appreciate y'all for coming out, and if I need anything, I'll give you a call back. Because one of the important things about, success in this program is just making sure you have that full circle of following up with the patient. So not just going out there, doing that assessment, navigating them. If there is a way that you can follow up with the patient within the 24-hour window, is there another opportunity of assisting that patient? Do they need, our specialist, or is there continued visits to that PCP or whatever? And just a customer satisfaction of getting that follow-up visit just to check in and see how they were doing. All right, some more relationship and marriage advice. So is it better to be single or married? So Anita says it's better for girls to be single, but not for boys. Boys need someone to clean up after them. I have 2 boys, well actually 3, so I understand. How would the world be different if people didn't get married? Kelvin says there sure would be a lot of kids to explain, wouldn't there be? Awesome. How would you make a marriage work? Ricky said, tell your wife that she looks pretty, even if she looks like a dump truck. Wow.
Yeah, he's going to be a serial marriage person.
Right. All right, you're up.
All right, so just to wrap up a couple of things. As Desi described, this was a gap that was brought to us, but something that we can, that you guys can look for in some of your local communities. The fun thing about the ownership of Trinity Terrace is that they are owned by a large national investor-owned conglomerate, and it is likely that they will have similar facilities in other communities, and some of those communities may be yours. So much like with hospice programs, we were one of the first hospice programs back in 2011, whenever we started doing it. Now it's become pretty common across the country. This could be an opportunity for you guys in your local community. Make sure that as you're doing this, remember this was based on our existing Star Saver program, our membership program. We just made it Star Saver Plus. Make sure that you're evaluating the economics and even the clinical side of all those things. Find out what the goals are going to be. So Desi and her team spend a lot of time. We do the same thing across the organization. What's your goal? What does success look like for you, so that we can structure a program that's going to meet their goals, their desires, and be successful, therefore be valuable, and want them to keep doing it. We don't want to do this just for 1 year. We want this to be an ongoing thing. Be realistic. Desi is always the ballast in the organization. So when we say, oh yeah, 2 weeks, come in, do these assessments, we're good. She said, no, it's probably going to be longer than that. Let's be realistic.
Yeah.
Don't be afraid to jump in. One of the things that we often say is that success, 50% of success is showing up. You got to take risks, and if you're not making mistakes, then you're not really innovating. So don't be afraid to try something new. As sort of a final thought, this is our space. So as Desi explained the program, a lot of the responses that we're doing are in response to a 911 call. And us on the phone in the EMS industry, we do that really, really well. Others are doing it also, but they are not, in many cases, integrated with the local 911 system. So if you think about Dispatch Health and their model across the country now, and again, investor-owned, they are growing like crazy. Ready Responders, I think everybody's pretty familiar with them. Most of the time that they are operating outside of the traditional 911 system. WellBe Senior Medical is an organization out of Illinois. They're actually coming here in January to learn about our program, to see they typically use nurse practitioners and PAs. They're thinking maybe we can use paramedics, maybe even EMTs in this role, and don't have to have that high expense. So others are doing it. Don't wait for someone to come into your market, your community, and start doing this when it was something that you could have done because you could bring that exceptional value to them. All right, with that, we're going to turn the floor, the podium, the internet back over to Gary Wingrove, and Desi and I are happy to take any questions that folks may have.
All right, we're going to unmute your lines, and then we'll be ready for a question and answer.
The conference has been unmuted.
All right, hearing no questions.
Any questions for Matt or Desi?
Wow, that's good, I guess. Gary, what we can offer to the team, obviously you're going to make the presentation available. If folks would like more information, even some of the workbooks that we use to do some of the economic modeling, if you'd like some of the support materials that we put together, the subscriber agreement, contact Desi, and she'll be happy to share that information with you so that you can do this in your local community.
Great. Well, thank you, Matt and Desi. We appreciate it. Kevin is always looking for people to share what they're doing, and so if you have something going on in your space and are interested in doing a presentation in January or some other month, please contact Kevin. And if there aren't any more questions, thanks for joining us today. Thank you, Matt.
Thank you all.